introduce Dr. Anyikam, I'm very excited to, I had a full peek into what she has for us today. And Dr. Anyikam is a maternal fetal medicine consultant at COVlD Corporation. She's certified by the American Board of Obstetrics and Gynecology. And in her slide, she'll be telling us what exactly, it's not a common term here, she'll be telling us exactly what a maternal fetal consultant does. But she has a whole lot of degrees that I will not go into, but just know that she's skilled to talk on the topic she's discussing. Over to you, Dr. Anyikam. You'll be sharing your slides.
Okay. Thank you again for allowing me to talk to such an esteemed group. And as I try to share my screen, thank you again for the organizers of this talk. It's a very important talk at this time of global crisis, as we can say in a nutshell. So as I was introduced, and you guys really researched a lot about me, my name is Dr. Anyikam, Adanna Anyikam, and I am a maternal fetal medicine consultant. So a lot of people don't really know, and again, I speak really fast, so if I'm speaking fast, just I'll slow down. But a lot of people don't know what a maternal fetal medicine specialist is. It just sounds like a very big title. So this is a person, including me, that's done 4 years of an obstetrics and gynecology residency, plus a maternal fetal medicine fellowship. We focus on high-risk pregnancies. We focus on 3 aspects of high-risk pregnancies. Now, if you can imagine, pregnant women were people before they became pregnant. So if you had a pre-existing medical condition, hypertension, diabetes, sickle cell, if you were quadriplegic, if you had cancer and you became pregnant, now you need specialized care because those pre-existing medical conditions affect your pregnancy and you want a good outcome. So I'm the person that helps to manage these complications. Additionally, you have a placenta that can be also complicated, that can increase the risk of preeclampsia, abruption, accreta, and previa. And the third final component, because we can't have a pregnancy without a baby, is that we use ultrasound technology to help assess the fetus prior to delivery and manage twin pregnancies, malformations like cleft palate, cleft lip, twin-to-twin transfusion disorder, genetic disorders. So keeping these 3 aspects in mind, the mother, the placenta, and the baby, our ultimate goal is to have a happy family and happy outcomes. So in a nutshell, that's the specialist that I am. What we're going to talk about today is the whole umbrella of that in this global pandemic. We're going to talk about and get a baseline understanding of COVID-19. We've all heard about it, so we all should be experts about it, right? And we want to understand now, which they really don't talk about in the news, is how COVID-19 can affect pregnancy and if pregnant women are at increased risk. And I think that was the very first question. So I'm definitely going to help answer that question pretty soon. And because we always have to bring it back to the Nigerian context, what are the guidelines of screening and treating diabetes in pregnancy in Nigeria compared to international protocols? Because we have to have an understanding of the normal things to do with diabetes on top of the COVID complications. And we want to understand, in the Nigerian context, the prevalence of this condition in pregnant women. And additionally, how are these pregnant women managed without COVID-19? And then on top of everything, pregnant women with diabetes, how are they managed when they have symptomatic mild COVID-19 disease? Now, we're not going to go into severe disease because I'm a maternal fetal medicine specialist. I'm not an intensive care physician. I've had women that have had severe disease and that needed to be admitted to the intensive care room, the intensive care ward. And in that capacity, I'm giving recommendations on how to manage the pregnancy, but the intensive care physician is the sole consultant that is in charge of that team. We're just going to focus on mild disease because a lot of us as practitioners can encounter pregnant women with mild disease. And again, we've seen this graphic for the past, I feel like it's been several years, but it's only been a few months. The virus is a huge family of viruses that have different family members underneath. And it's this new family member that's been causing problems, this novel COVID-19 that's been causing problems that we're focusing on. And there's a lot of symptoms that you can have when you have the coronavirus. And all of us as practitioners and people listening have to understand that it has to just come off on the top of our heads. We have to think, okay, if somebody comes in with a fever, dry cough, tiredness, loss of taste and smell. Now, there could be a large group of conditions that they can have, but we have to have a high suspicion of COVID-19. So we have to just put this to memory. And then we know the transmission, because we've been social distancing, is through person-to-person contact, through small droplets, nose and mouth and things like that. So the question is, our friend Anyikam lives in Lagos, right? She's 23 years old. She's 7 months pregnant. She's had one normal birth about 4 years ago, and she is very healthy. She doesn't have any medical problems. The question Anyikam has for you, the question her mom has for you, the question that everyone in our household has for you is Anyikam at a higher risk of having symptomatic COVID-19 compared to non-pregnant women? This is the main question that has been popping up since this pandemic came out. And I'm not going to answer it right now. We're going to take ourselves through the thought process of how we can actually answer this question. Whenever we have a new question, we go back to old answers. So let's just think about non-pregnant people. So we know through watching the news, through reading reports, that if we break non-pregnant people into healthy and unhealthy, the healthy person, anyone can go through this scary green box, right? But the healthy person is at a better chance of either not getting COVID-19 or getting asymptomatic COVID-19 or mild symptoms and recovering easily, okay? They also have a risk of getting into this scary box. However, the unhealthy person has the higher risk of getting into the scary box, having symptomatic COVID that becomes severe, that they'll have lung findings, dyspnea, pulmonary infiltrates, which are signs of respiratory failure, and that can lead to acute respiratory distress syndrome and even death. But we know that not everyone that goes into this box ends here. You can recover, and not everyone is going to go into that box. So if you ask me, who is at increased risk of having symptomatic COVID-19, those are unhealthy people with pre-existing medical conditions who are not pregnant. We know that. But the question is, do healthy pregnant women, maybe they follow the same path as healthy non-pregnant women? This is a question that we need to really understand. So why are we asking this question? What determines the difference between pregnant women and non-pregnant women? Well, we know that pregnancy is this 9-month phase, and there's a lot of physiological changes. So the question really is, what changes in the respiratory system occur in the pregnant woman compared to the non-pregnant woman that can cause her to be at higher risk, okay? And do these changes increase pregnant women's risk for symptomatic COVID infection? And if they become symptomatic, are pregnant women automatically going to have severe disease? That's the question that we need to ask. And So when we're asking those questions, we think about the changes of pregnancy. We can break them into the anatomical changes, the physiological changes, and the acid-base changes. Not everybody here is a specialist, but everybody knows what a pregnant woman looks like. The uterus gets bigger. It makes the diaphragm rise. Will this change the way that someone's breathing if they get sick? We know that pregnant women that get influenza do worse than non-pregnant women. Is this the same with COVID-19? We don't know. Going into the respiratory physiological changes. Now, anytime a busy slide comes up, people start groaning. This slide just needs to highlight that you have an enlarged uterus, and then you also have physiological changes that involve progesterone. Progesterone helps you make a baby, right? So your baby is growing and your baby's going to need oxygen to form the cells and everything like that. So progesterone helps increase the oxygen consumption, because you yourself, as you're living your daily life and growing a baby and your baby's growing, you're going to need increased oxygen consumption. And this is going to change some of the indices. And the reason why the way that the uterus is enlarging, it's going to change some of the lung volumes. And I'm not going to really go into it. But do these changes plus the anatomical changes make you weaker in the face of COVID? And finally, the acid-base changes. And again, this is a bit complicated, but not really. So we always have to know that pregnancy normal values sometimes are different than non-pregnant values. And just like I said, because there's an increased oxygen consumption, there's an increased fetal waste of carbon dioxide. Now, the carbon dioxide has to get out of the mom somehow. So it goes from the fetus to the cord to the placenta to the mom, and it causes different changes in ions and bicarbonate levels. So the key point is there's a mild respiratory alkalosis, which is normal in pregnancy. And if you saw this in a non-pregnant person, you would think there was something wrong. But because now you understand the differences in pregnancy and non-pregnancy, you know it's normal. So do these changes now put her at an increased risk? Let me move this down here. This is the question. So we can answer that just by conjecture, just postulating based on the anatomical changes, the physiological changes, and the acid-base changes. But ideally, there's probably a place where there's a whole bunch of pregnant women that were, screened or had COVID that we can just follow, a cohort of women. And if there was a place, we can look at that outcome of those women. And luckily, there was a place. And that place was called New York City, okay? In the US, New York City was and remains the epicenter of the crisis. So what happened between March and April at New York Presbyterian Hospital is that roughly a little over 200 women came in for labor and delivery. They instituted a policy where they did universal screening for every woman. So these women aren't coming in because they have a cough, loss of taste or smell or fever. They're coming in just to have their baby. And because there's so much issues with COVID-19, they decided to universally screen these women. And they found that they all came in, they all did well, and they were all discharged. So looking at their data, now, if you think, okay, if you're pregnant, automatically you're gonna get COVID-19. Whether you're symptomatic or not symptomatic, every pregnant woman around here should have a positive test. That is not what the New York people saw. Of the over 200 women that came in, the vast majority were negative. And these are people that are all living in the epicenter of the crisis. There's nothing different between those women that didn't get it versus those women that did. Well, we're assuming that because, again, this is just an observational study. So based on this, and unfortunately, it has to be based on observational information. Based on this, we can say that Anyikam is not at a higher risk of having symptomatic COVID-19 just because she's pregnant. Because then we would expect to see, okay, maybe not 100%, but maybe a large percent of all the women that came into delivery to be positive, but the vast majority were negative. So this is actually pretty reassuring, okay? Today, this is reassuring. Now, things can change in 4 or 5 months, but this is the information that we're going on. But the most important thing is, at your facility, where you are you doing universal screening? The answer is most likely no. And so what we have to remember is that up to almost 15% of these pregnant women were asymptomatic. So I don't care where you are in the health practitioner spectrum. You need to always treat everyone with a high suspicion, because now if you think, okay, well, most pregnant women, they're not going to be symptomatic. Well, you don't know if they're asymptomatic and have COVID-19 and then infect yourself. So you have to be very aware that pregnant women can be walking around fine, asymptomatic, And as you as a practitioner can now get infected and it can infect you. So you have to always protect yourself. Now, does that mean that whenever the women come into your facility for delivery, you're using full PPE? No, but you should have a policy where you're instituting masks. Just because you see a pregnant woman that's doing fine doesn't mean she doesn't have asymptomatic COVID-19. But are you sure? Okay, so in New York, all those women came for delivery. But what about if she had symptomatic COVID? You still didn't answer the question. If a woman who's pregnant has symptomatic COVID, does she automatically have severe disease? So if Anyikam has symptomatic COVID, will she have more severe disease than a symptomatic non-pregnant woman? And once again, there aren't any randomized controlled trials about this. We don't really know, but these are also good questions to ask. So how are we going to get that answer? Is she at higher risk for severe disease if she gets it? So we know that she's not at higher risk of being having symptomatic COVID, but what if she is symptomatic? Does that mean she's going to automatically be severe? And luckily, there was another place on the other side of the world in Wuhan, China, where it all began. So they looked at women that came in specifically to the hospital with symptoms. So they're looking at a little less than the New York population, a little bit over 100 women that only came in for symptomatic COVID-19. So if you think that, if you're pregnant and you have symptomatic COVID-19, it's done. You're always going to be severe. That's not what they saw at Wuhan. The vast majority, 92%, had mild disease. 8% had severe, with the symptoms and the chest x-ray findings, and there were no deaths. Everyone pretty much did okay. So, answer to that question that based on the limited data that we have on these limited cohort studies in Anyikam, a healthy pregnant woman is not at a higher risk of having severe disease if she has symptomatic COVID-19 compared to healthy non-pregnant women with symptomatic COVID-19. So it's a little confusing, but I'll repeat it again. Anyikam, who's healthy, is not at an increased risk of having symptomatic COVID-19. Anyikam, who's healthy, if she eventually becomes symptomatic with COVID-19 and is positive, that does not mean she will automatically have severe disease. And hopefully that makes sense. So Anyikam has a neighbor. What about Anyikam neighbor, Sharon? Now, although they live nearby and they're both 7 months pregnant, they're very different. Sharon is 41. She has high BP. She has diabetes. She takes medication for her diabetes. She's had 5 natural deliveries. She's had preeclampsia in 3 of her pregnancies. She's a bit heavy and she doesn't exercise. So Anyikam comes back home or gets off the phone after you spoke with her, and she tells her neighbor Sharon, I'm not at increased risk because I'm healthy. I don't have any pre-existing conditions. This pregnancy is not weakening me to COVID-19. So Sharon wants to know, okay, what about me? So Sharon, even though she's pregnant, we have to think about her in the spectrum of what we know about non-pregnant people. We know that this unhealthy person definitely can either not have COVID-19 at all or be positive and asymptomatic and recover. But this unhealthy person compared to the healthy person is at an increased risk of getting into the scary green box. So what about the unhealthy pregnant patient with pre-existing medical conditions? What is their risk? And we have to suppose, based on what we've seen in studies, is that, and not really studies, but observational case reports, is that Sharon is just like the unhealthy non-pregnant person. She is at increased risk of having symptomatic COVID because of her pre-existing medical issues. And it doesn't mean that she will automatically have severe disease, but she is at a higher risk of developing from mild to severe because of her pre-existing conditions. So the key issue is the pre-existing medical condition. Pregnancy and the changes of pregnancy don't necessarily weaken you and increase your risks so far as what we know now, but it's the pre-existing medical condition on top of the pregnancy that changes everything. And there's a lot of pre-existing medical conditions in pregnancy: seizures, Crohn's disease, lupus. We're going to focus on diabetes. So this just shows the diabetes in pregnancy, how that is a pre-existing medical condition, meshes with the COVID, and how we're going to manage that to have the best outcome. Briefly, we all know that diabetes is just too much sugar in the blood, hyperglycemic, that affects the cells at the cellular level, that causes a lot of problems. Strokes, strokes, blindness, heart attacks, you don't have very good circulation. So when you're trekking from work to home, something can pierce your sandal and you can get a cut. That cut doesn't really heal very well, becomes a non-healing ulcer. Next thing you know, you're getting amputations, and then also vision loss as well. But what does this have to do? Because we have type 1, type 2, and gestational diabetes. Why do you get diabetes in pregnancy? Like, I don't understand. I'm not getting the connection. Well, I'm going to tell you the connection. Very briefly, pregnancy endocrinology is very complex, but let's just break it down so we can all kind of remember. So the pancreas creates insulin, and that insulin modulates glucose. It makes glucose takes it out of your blood to your tissues so you can do things, okay? When you're pregnant, you have a placenta. So this is very, very just watered down and just basic. So the placenta ideally wants your blood to be, let's say, transiently sugary, because if all of your sugar now goes to your thighs, goes to your brain, goes to your arms, and you're doing things, you won't have enough quote unquote sugar for the baby. So the placenta wants your blood to be transiently sugar, so enough goes to the baby so the baby can grow and develop. But very quickly, you go back to your euglycemic state. So Anyikam, if she doesn't have any issues with gestational diabetes, she eats a nice plate of jollof rice. She takes her blood sugar 2 hours after, and you won't even see this transient hyperglycemia. You only see the normal values. But what if Anyikam has gestational diabetes? Something goes wrong. This P2P interaction, the placenta and the pancreas, something is off. So you do have this transient hyperglycemia. It goes to the baby, but for some reason, there's sustained hyperglycemia. This is what we don't want. This is the gestational diabetes issue. Okay, and it's bad for many reasons. There's a maternal risk of preeclampsia, cesarean delivery, having a very big baby that gets stuck as it's trying to come out, shoulder dystocia, and there's fetal risks as well that are listed here. So because of that P2P interaction, maybe there's something off with your pancreas, and the pregnancy is giving us a glimpse of the future. So we know that women that have gestational diabetes have an increased risk of developing diabetes later on in life. Bringing back to our Nigerian context, ideally there should be standard guidelines for all of the regions, but unfortunately, the literature is not very readily available. So we'll talk about the Lagos guidelines context. So a lot of the studies that have shown the prevalence of diabetes in pregnancy are from teaching hospitals, and there's very limited data about the different prevalences in different regions in Nigeria. But it's about less than 2% of women have diabetes in pregnancy. Of that 2%, 40% are pre-gestational diabetics, 60% are gestational diabetics. Is this a lot? Not really, because if you estimate about 7 million births a year, this is not that many people that are affected with diabetes, but the diabetes consequences are pretty significant. And the regional differences of diabetes in the Nigerian pregnant population is just, we have to do a better job of collecting this data. And that's why we're all on this call. So the risk factors of getting gestational diabetes, I'm not going to go into it, but remember we talked about that P2P interaction, your pancreas to your placenta. So if you were overweight, if you had a prior history, if you had a family history, that increases your risk of going through that gestational diabetes spectrum as opposed to the normal spectrum. So how do you know you have gestational diabetes? You can't really tell, right? So there's different screening protocols. And again, this slide is busy. We're not going to go through all of this. Just know that there's different screening protocols that involve an oral glucose challenge. You get a nice little shot of glucose. It's like very, 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 very sugary Fanta. And they give it to you, and they check how sugary your blood is at intervals. And if your blood stays sugary, remember how we're saying transient hyperglycemia, but if it's sustained, then that P to P interaction is making you gestationally diabetic. And the good thing about gestational diabetes is that you are diabetic while you're pregnant, because after pregnancy, you keep the baby, you throw away the placenta, right? And so now you no longer have the effects of the placenta on your body. So screening, surveillance, intervention. This is going to differ through all of the sites. We can sit here and have another 3-hour discussion about gold standards, but when it comes to implementing those gold standards at your site, you always want to do the gold standard, but what can you do today to get you one step closer to the gold standard? So the gold standard for screening is universal screening of all pregnant women between 24 to 28 weeks with an oral glucose challenge test. This may be cumbersome for some sites that are less funded versus some sites that are better funded. Now, if you can't do this, what are your alternatives? Well, maybe a random glucose in each trimester, maybe as you're trying to build capacity towards that gold standard. But if you just do a urinalysis, dipping the urine to see if there's glucose, that is not, you can't really call that a screening test. Now, you may do it until you get capacity to do a random glucose, to do a capacity to do the gold standard, sure, but a urinalysis is not sufficient enough. And if you can't universally screen because you don't have the capacity, you should start thinking of screening based on risks. And that was the risk factors of gestational diabetes that we went through. So a woman now is positive for gestational diabetes. What next? Well, you're supposed to see how hyperglycemic she is all the time. So the gold standard, remember, we're always talking about gold standards, but we're working our way eventually to that. Maybe not today, maybe not tomorrow. You're supposed to, as the gold standard, check the glucose values 4 times a day, fasting and after every meal, breakfast, lunch, and dinner, okay? And then after 2 weeks, if there's persistent hyperglycemia, despite lifestyle modifications, diet and exercise, then you do medical intervention. And insulin is the gold standard. Now, if we do the mental math, let me move this up a little so I can see. If we do the mental math, you get screened between 24 and 28 weeks. A woman comes in, she's screened at 28 weeks, okay? And now she's planning to deliver at 29 weeks. So she's supposed to check her blood sugar 4 times a day for 11 weeks. That's 308 times. Now, all this equipment is not free. It's not provided by the clinic, unless you go to a really great clinic. I don't know. But most women are going to have to pay out of pocket. So that's why when you're talking to the patient, you have to see if it's feasible for her to do it 4 times a day. If not, we may just have to just get the fastings only and random during the day and try to clinically extrapolate from that. And again, lifestyle modifications, if you test positive, we need to talk about not gaining too much weight. We need to talk about the rice, the plantain, the indomie, the apple, the gari, boiled yam, fried yam. All these delicious foods have to be taken in moderation and even eliminated from the diet. And if you fail at making your values normal, then the gold standard is insulin. So how do we choose the medication? Well, we choose it because the gold standard is insulin, right? But there's some perceived cons and some perceived pros. Insulin does not cross the placenta. It's easy to titrate to increase small or increase large. However, it's costly. You need the supplies, you need the needles, you need the alcohol pads. Patients can be non-compliant, and there's a theoretical risk of hypoglycemia if the patient gives themselves too much. Glucophage is relatively cheap, as well as glyburide, and it doesn't, but theoretically they cross the placenta. But insulin is the gold standard. So what's the whole point of even bringing this up? Some researchers are saying, well, even though insulin is the gold standard, it's not contraindicated, because there were 2 randomized controlled trials that did head-to-head metformin versus insulin, glyburide versus insulin, and they found that there were no deleterious fetal effects. And so there were considerable alternatives to insulin. So Why would someone want to do alternatives to insulin? Well, yesterday I called around in Ikeja, a pharmacy which will go unnamed, to ask how much are these things, because we always want to bring it back to the realities on ground. Glucophage, they said 500 milligrams is about 1,200 naira. Insulin varies, but the starting costs are about 5,400 plus all the supplies. They didn't have glyburide, so I didn't know. So again, you didn't realize you're going to do a lot of math today. Let me move this out of the way. So if glyburide, she called the pharmacy. If glyburide is, if the diabetes mellitus is diagnosed at 28 weeks and the woman now fails after 2 weeks and she says she's not sticking herself, glucophage can be prescribed 500 milligrams twice a day. If she's going to deliver at 39 weeks, that's 63 days. That's 126 tabs, that's 6 sachets, that's 7.2, right? So that's still expensive, but it would be a lot more expensive for insulin. So again, insulin is the gold standard, but these are some of the roadblocks that you can encounter. It's the affordability of the management plan that you are enacting. So now that we have a global view, let's talk about COVID-19 and pregnancy and diabetes. This is an actual true case of a patient that I'm actually managing. It's a 39-year-old African woman who's 33 weeks pregnant. She's had 8 prior vaginal deliveries that were uncomplicated in her East African country. She recently immigrated from to the US. This is important because she denies having a history of diabetes in prior pregnancies, but upon further asking, she went to a clinic that did not universally screen for diabetes and didn't risk screen for diabetes. And so she never got a challenge test. So we don't really know if she had diabetes in pregnancy, and she is a bit heavy. She presented with 4 days of cough, subjective fever, sore throat. So we had a very high suspicion for COVID-19, even though her temperature wasn't above 38 degrees centigrade when she came in. And even though she was breathing at 97% room air, her point of care glucose on admission was 200. So this is an important slide. I was gonna make this bigger, but I forgot how to do that. So just bear with me. So how
Dr.
do
we can share we can stop sharing and share it as a Word document.
Okay.
So we can, is that open for you?
It can be.
I have it open so I could share it on your behalf.
Can you? Okay, perfect.
Annie, can you go ahead and share the Word document?
So while we're waiting for that, remember how I was saying you have to remember all the symptoms of COVID-19, but don't automatically assume, okay, if their temperature is not 30, okay, perfect. So if their temperature is not 38 degrees centigrade, then they don't have COVID-19. It's not an all or nothing. You should have a high suspicion. So temperature, yes, off the bat, if it's 38 or more, then definitely a high suspicion. But any combination of these issues should lead for a high suspicion. So in the Nigerian context, people that come in to the hospital, everyone is admitted. Yes,
Sorry to butt in, but can we have it zoomed in more?
Oh,
so that people
I can
no, not you.
Oh,
not you. I'm speaking.
Okay. And then can you push the tab, click right here to move this toolbar up? I mean, it's not that. Okay, perfect. So, so in the Nigerian context, in the facilities that I was talking to practitioners, everyone that comes in with suspicion gets admitted. In the US, in the hospital that I'm in, you don't necessarily get admitted if you have low suspicion, which is at the bottom. So it just depends on your facility. So this slide is important because if you're admitting everyone and testing everyone, they're positive, you need to realize how to triage those with severe and then those with moderate disease. And so asking these screener questions to figure out who's going to the elevated risk, who's going to be needed more of the intensive care, multidisciplinary team watching them and having close eye so they don't decompensate, versus other women that have, can you scroll up? Can you scroll up? No? Okay. Well, anyways, this box here talks about comorbidities and pre-existing, perfect, comorbidities and pre-existing disease that puts you at the moderate risk, but both of these are still being admitted and treated. Okay, we can go back to, I go to my screen share. Okay. So, okay, perfect. All right. Okay. All right. So for here, depending on your facility and if these low risk women can be managed as an outpatient, if they can socially distance, usually that question is no. And in the Nigerian context where I spoke with different colleagues, they said all women that are pregnant are admitted and monitored. So for this woman who again, she's 33 with newly diagnosed and poorly controlled diabetes, morbid obesity, she had a positive COVID swab when she came in. We did continuous pulse oximetry. She was on room air and she was able to sat up to about 98, 97. She never went below 97, which is good because ideally we want it to be 95. We were monitoring her vital signs every 1 to 2 hours. She didn't have a fever on that day one. We were doing a physical and obstetrical exam. We did glucose monitoring and we did baseline labs and a chest x-ray. So this, depending on your facility, this kind of seems like most facilities can do that standard workup. So what's extra, depending on the capacity of the lab, is these inflammatory markers. And the importance of these inflammatory markers is that it's not always going to be the same as a non-pregnant patient. So it's important, if you can save this slide for your future reference, these are the normal values of these indices in pregnancy. So typically laboratories show normal values of non-pregnant people. So you need to know if something is actually abnormal. So the C-reactive protein in her case was abnormal and the D-dimer was abnormal. But you can see the D-dimer in pregnancy in the 3rd trimester can be as high as 1.7. So we ended up doing also a hemoglobin A1C that was 7% for her. So it shows that she had pre-existing diabetes. Cardiac enzymes because she was having chest pain, troponins. We did a sputum culture, TB tests to rule out other etiologies as well. And of course, while we were seeing the woman, we were using PPE. Now, this is from the CDC. This is the preferred PPE, and the difference between the preferred and the acceptable is that there's an N95 or higher respirator here versus just a regular mask with the shield. And so we talked about in the other lecture differences in PPE, but at least have a face mask and a shield and a gown and gloves to prevent infection from yourself and also spreading infection to other patients. So this is from the literature because what are examples of a positive chest x-ray in a COVID positive patient? So this patient on day 1 of her admission, she had diffuse bilateral infiltrates in her lower lobes. And then it progressed to a consolidation as she required more oxygen requirements, and they took another chest x-ray on day 5. Now I know what you're asking. How safe is chest x-rays in pregnancy? What amount of radiation is too dangerous for the fetus? So these are the threshold doses that are pretty dangerous for the fetus, especially at 16 weeks to 25 weeks. Early on, you're talking about errors in organogenesis. Later on, you're talking about intellectual disability. But these are really, really, really high doses of radiation. A chest x-ray, it's not that much radiation. And women should have abdominal shielding even to reduce the amount even further. And even a CT is not that much radiation. So Mrs. TA on day 1, she had a little bit of some opacities that looked like something was there. We repeated it on day 3 because she had increased oxygen requirements that needed nasal cannula support. And this definitely is consistent with increased haziness and bilateral opacities that we see with COVID-19. Now, do you need to repeat that chest x-ray if the patient is exhibiting signs and findings? No, you can just act clinically. So what did we do for her? So she had a mild case of COVID-19 disease. It's always supportive care, serial vital signs, clinical exams, providing nasal cannula to maintain adequate oxygen saturations. However, it should be known that if she worsened, you should avoid BiPAP because this can increase aerosolization of the virus in the air and then infect everyone around, including the staff. The most important thing that we have to remember is that pregnancy is a hypercoagulable state. COVID-19 increases the risk of clots as well, so she needs to be anticoagulated, and she was on prophylactic anticoagulation. And yes, you have to have caution with IV fluids. You're talking about a disease that compromises the respiratory system, so you don't want to fluid overload these patients and exacerbate their situation. Consider antibiotic therapy with azithromycin. That's on a case-by-case basis. Plaquenil was not used on this patient, and the use in pregnancy, even though we use it for lupus patients, it's just cautioned because it can increase the QT. It can prolong the QT prolongation. And remdesivir, which is a drug that is now used for compassionate care, was not considered in this case because she's not severe. And compassionate care is when you use a new unapproved investigational drug to treat someone who's very, very ill and you have no other options. It's not that it will directly attack the virus, but it may help your body and for your body to fight off the virus, but it wasn't given in this case. And of course, we did fetal monitoring every 12 hours versus continuous monitoring. We told the neonatal ICU that the patient was admitted. We didn't give steroids for fetal lung maturity acceleration because she had poor glycemic control. And we did a fetal growth ultrasound to show that this was a severely macrosomic baby. This baby was 3.5 kg at 33 weeks. So that's abnormal. So in severe disease, which is not the presentation, is prone positioning possible in pregnancy? Yes, it's feasible. These are for very, very, very severe cases. Now, you're always balancing the maternal and the fetal benefits. So in severe cases, whether the patient is intubated or not intubated, you can consider patting the woman and supporting her belly and putting her prone to have the benefits of proning in COVID-19 severe disease. And those benefits have to do it, but you can consider it. So if a woman has severe disease or mild disease, is that an indication for delivery? No, it's not an automatic indication for delivery. The timing of delivery in critically ill patients should be individualized. If a patient is on a ventilator, will delivery of the fetus, meaning evacuating the uterus, help to improve maternal oxygenation? It's really unclear because in the late 3rd trimester uterus, that it may account for some mechanical restriction and ventilation, but it doesn't automatically mean if you deliver the patient that she'll get better, especially if she has very severe disease and now you make her undergo an operative procedure like a cesarean delivery, and that can actually worsen her complications. Or if she goes through a vaginal delivery, postpartum, you have different fluid shifts that can actually worsen a respiratory illness. So delivery is not a knee-jerk reaction. It has to be individualized. And just because a woman is intubated does not mean she has to be delivered. So Mrs. TA's course. Day 1, she was admitted, like we said, supportive care, initial evaluation. She didn't require any oxygen. She was on room air and she was started on prophylactic anticoagulation. This chart is done side by side because whenever someone comes in pregnancy with a pre-existing condition and COVID-19, you have to manage them both simultaneously and understand that one may affect the other. Having a viral illness can make you hyperglycemic. So maybe this was also the reason that her blood sugars were very difficult to control. However, by day 3, remember we said that healthy women who have symptomatic COVID won't necessarily become severe. By day 3, she was worsening in her respiratory symptoms, requiring 2 liters of nasal cannula of oxygen. And we also started her on insulin to help with the hyperglycemia. By day 4, she spiked a temperature, and we were thinking, this woman's going from mild disease to severe disease. But interesting enough, she was starting to complain of leg pain, and so we did lower venous Dopplers to find out that she had a deep vein thrombosis in her left deep femoral vein. This is important because initially we just thought that she was just decompensating because of the COVID-19. But it turns out that the increased tachypnea and the respiratory issues were secondary to her blood clot. So we switched the subcutaneous prophylactic anticoagulation to IV unfractionated therapeutic anticoagulation. And she eventually improved by the end of the next day. She was weaned off the oxygen. So we thought, okay, she's complaining of leg pain, so she has a blood clot. Maybe the blood clot, she also has a pulmonary embolism. So before we did a CT of her chest, we did the lower extremity Dopplers. And the lower extremity Dopplers were positive. You treat a DVT the same way you treat a PE. That's why we didn't do a CT, just in case anyone asked. She started improving with her lungs, her respiratory status towards the end of day 6, that she was able to wean off of oxygen. And then through day 10, and I think we're on like day 15, she's still on IV heparin therapy for anticoagulation. So she's on IV therapy for, she's on IV heparin as opposed to switching her back to sub-Q, because she refuses sub-Q injections. So we're keeping her on IV unfractionated heparin. And we were able to eventually educate her about diabetes, nutrition, and get her on an insulin regimen that was helpful. So her long-term hospital course, unfortunately, she has issues with compliance. In terms of respiratory symptoms, she has improved significantly. We retested her and she's still COVID positive. But she could go home with subcutaneous heparin and follow up, but she refuses to inject herself with heparin. She anticoagulation, anti-blood clot medication, and she'll follow up in diabetes clinic, and she's gonna go on oral medication because we use the interpreter, because she speaks Swahili, to talk to her about the differences and the importance of this medication. We talked to her husband. She and her husband said that they're not injecting anything. So she's going to have to just go on oral medication for everything. So that was a lot of information. But in summary, pregnancy alone does not increase the risk of COVID-19. Today, this is what we understand. And it doesn't increase the severity of the disease. Pregnancy plus a pre-existing medical condition can increase the risk of symptomatic COVID-19 and severe symptomatic COVID-19. And also be aware of quickly changing status to moderate to severe. This can happen quickly in COVID-19 positive patients, but you should also rule out other etiologies such as blood clots, such as a whole myriad of things that can be that can be because of COVID-19, but not necessarily just the COVID-19 on the respiratory status. And then also remember, interpretation of lab values, you always have to know the normal lab values in pregnancy because they can differ in the non-pregnant state. And severe disease requires a multidisciplinary ICU team to help out. And things are always changing. Now, we answered Anyikam questions and Sharon's questions, but they may have different answers as we understand the disease more and more. So these conclusions regarding COVID are just from cross-sectional data in the last 5 to 6 months. As more definitive data evolves, recommendations may change. So you need to keep abreast with your local government health department rules and regulations regarding COVID-19 management, and always protect yourself. That is it. I probably should stop sharing. Okay, good. That's it. Any questions?
Thank you so much, Dr. Anyikam. That was really, really well presented, well thought out, and addressed, a whole range of services that we offer. Pregnancy, care of the pregnant diabetic mother, going through whether she's asymptomatic or symptomatic, and if she's now symptomatic, going through management of the, what to look out for severe cases, mild versus severe cases. So thank you so much.